Unit 9, Obsessive Compulsive and Related Disorders. 9.2 Introduction. One psychiatric disorder, which has probably been extensively studied and has gained immense curiosity, is obsessive-compulsive disorder, OCD. Ever wanted to wash your hands frequently so that you were clean and tidy? Wanted to keep things neatly arranged in your room and felt annoyed if things were missing from their place? Had doubts whether the bathroom geyser switch was left on after leaving the house? Felt the need to itch and scratch your scalp when feeling tensed? Peeled the skin from your nail cuticles or surrounding areas? Many of us might have experienced or may be doing these things. But when are these reasons enough to be worried and seek professional help to overcome these? In the present unit, you will be acquainted about obsessive-compulsive and its related disorders. OCD was earlier considered to be an anxiety disorder, however, DSM-5 classifies it under the group called obsessive-compulsive and related disorders, OCRD. OCRD includes a group of disorders, which has compulsiveness as a prominent characteristic feature in their psychopathology, with anxiety having no functional relation to the compulsive symptoms. The disorders that make up OCRD are body dysmorphic disorder, trichotillomania, excoriation and hoarding disorder. In this unit you will learn about two important and commonly seen disorders, obsessive-compulsive disorder, OCD, and body dysmorphic disorder, BDD. 9.3 Obsessive-compulsive disorder, OCD. Box 9.1, Arun's story. At 9 years of age, Arun was pursuing his studies in school when started getting repeated, intrusive thoughts of death of family members and would often go and check his parents' room to check whether they were alive or not. He would often call them when they were not home and would fear them not being around him. His parents thought this is a normal childhood fear and that he will grow out of this eventually. As he grew older he started getting afraid of looking at figures of God, as he would get abusive words in his mind and thought that he was abusing God. This led to him avoiding going to the temple. He would close his eyes when he would cross the small temple at home and would immediately go to his mother to confirm whether he said something bad about God or not. This started affecting his studies, as whenever he would get these thoughts while studying he had to stop reading and had to chant mantras twice to make him feel better. He started becoming overly cautious of not doing anything immoral. He had strongly held superstitious beliefs, which made him pray for hours sitting alone in his room. He would occasionally go down to play with other children, however, he couldn't find anyone who could relate to his thoughts and felt like the odd one out. While he struggled with these thoughts for years, he only came to seek treatment when he was 22 years old, as his studies were suffering immensely. He could not clear his exams on 2 different occasions, because of which he started feeling low, would not get out of his bed for days and would get thoughts of being worthless. Obsessive-compulsive disorder, OCD, involves the presence of unwanted, intrusive and repetitive thoughts, images or urges that are accompanied by compulsive behaviors performed to neutralize the distress associated with obsessions or to prevent some feared situation from happening. The persistent, repeated and intrusive thoughts of death of his family members, getting abusive words in his mind, thoughts of abusing God are all different types of obsessions that Arun was having. By very nature, obsessions can be of different types and forms, see box 9.2 below, like they can come as thoughts, impulses, images that can be highly distressing to the individual experiencing them. As you saw in Arun's story, his studies started getting affected. He reduced his social interaction as he felt like the odd one out, and interactions with family were also strained. Usually, we find that people who experience obsessions try to resist them as it causes considerable disturbance and anxiety to them. In doing so, they often tend to engage in behaviors that reduce this distress. These take the form of compulsions. In Arun's case, he was constantly trying to see whether his parents were alive or not, chant mantras, and he started avoiding going to temple altogether. Compulsions, like obsessions, can also be of different types. See box 9.2 below. They can either be overt, such as doing an action physically, or can be covert, such as repeating something in one's mind, words, numbers, sentences etc., that reduces their distress momentarily. While there is a sense of relief from the distress or feared consequence after performing these compulsions, they can take the form of rigid rules in which the person feels compelled to perform them, which further increases their distress. A patient with OCD possibly knows that both the obsession and the compulsion are irrational, hence we call them as ego dystonic or something which is unwanted. OCD has a heterogeneous presentation among those diagnosed, characterized by various presentations of obsessions. It has been found that obsessions related to contamination are present in about more than half of the people diagnosed with OCD, and is considered one of the most disabling among other presentations of obsessions. Along with the above-mentioned features, the diagnostic criterion for OCD in DSM-5 mentions that the obsessions and / or compulsions must be time-consuming, at least an hour per day, and / or cause significant disruption of one's socio-occupational functioning. An important aspect of the criteria is the insight level of the patient, which may be either good or satisfactory, poor, or one where the patient has no insight / delusional convictions. The patient thinks with utmost certainty that his / her beliefs related to OCD are entirely true. Having poor or no insight can lead to a poor prognosis as well as impact a person's motivation in treatment. Furthermore, the criteria also emphasize on investigating whether the person has a present or past history of tic disorder. Prevalence, age of onset, and gender differences. The lifetime prevalence of OCD worldwide is estimated to be around 1.5% for women and around 1% for men. Estimations among adults in USA are slightly higher, being 2.3%. In India the estimate is around 0.8% for adolescents and between 0.5% to 3% in adults. Within India, early age of onset of OCD has been linked with the presence of sexual obsessions, hoarding, repeating rituals and compulsions involving need to touch. Worldwide, females have been found to have OCD at slightly higher rates than males in adulthood, although males are more commonly affected in childhood. Furthermore, younger adults may be more likely to experience OCD in their lifetime than older adults. What makes studying about OCD even important is that this is the fourth most common psychiatric disorder in the world, with disability associated with severe cases often comparable to the disability associated with schizophrenia and bipolar disorder. Comorbidity. Depression and anxiety disorders, panic, generalized anxiety disorder and social phobia are the most common comorbid with patients seeking treatment for OCD. Other common comorbid disorders include bipolar disorder, tic disorders, body dysmorphic disorder, trichotillomania, hypochondriasis and skin-picking disorder. Attention deficit hyperactivity disorder, ADHD, and oppositional defiant disorder, OD, are highly comorbid in patients with early onset OCD, especially when the onset is in childhood. Nearly a third of schizophrenia patients report OC symptoms or OCD. Personality disorders such as obsessive compulsive, anxious avoidant, schizotypal and borderline personality disorder are also relatively commonly comorbid with this illness. 9.3.1 Etiology of obsessive compulsive disorder. Genetics. Family and twin studies have shown that genetic factors are reasonably involved in OCD. They have indicated that not only one but a number of vulnerability genes are involved in the transmission of OCD from one family member to another. Interestingly, the family members of patients with OCD having higher number of obsessions related to checking, symmetry or ordering, were seen to be at a greater risk of developing OCD themselves, than were relatives of patients with OCD who had low scores on these obsession domains. Neurobiological mechanisms. The orbitofrontal system of our brain connected to the thalamic area, mediated by a neurotransmitter called glutamic acid, is implicated in OCD. While a second loop connects the same system via the corpus striatum, which controls the amount of activity within the systems. When this system fails to balance out the overactivity in the orbitofrontal thalamic loop, an individual keeps repeatedly responding to his or her environment. This leads to the development of OCD. The neurotransmitters implicated in this system include serotonin, dopamine and GABA. Psychodynamic models. Freud viewed the development of OCD as a result of fixation at and regression to the anal sadistic stage of development. He proposed that this fixation and regression was a possible consequence of strict toilet training in infancy. This behavior had elements of aggression and exercise of control over others associated to it. Thus, he called these patients as having an anal type character represented by traits such as parsimony, obstinacy, and orderliness. The anal character could then take on an anal retentive personality type, manifested as psychological rigidity as well as an excessive need for control, or it could also take the form of an anal expulsive personality type. Carl Abraham extended his work by proposing that in the anal stage, one phase has retention as the dominant theme, which becomes the source of enjoyment, and another phase where sadistic urges towards others take dominance and the pleasure is received from emptying one's bowels. 3 ego defense mechanisms usually seen at play in OCD are isolation of affect, undoing, in the form of compulsions, and reaction formation. Another psychoanalytic theory conceptualized OCD as a conflict between the ego and superego, as well as that between aggressive, sexual impulses emerging from the ID. Thus, the repeatedly occurring obsessions were primarily seen as an expression of unacceptable aggressive or erotic impulses, as well as may be a punishment received by the ever so strong and harsh superego. Adler tried to further these conceptualizations and put forth his understanding of OCD resulting from the person's failure of feeling in control of his or her life situations. He understood compulsions being unconscious attempts of a person to compensate for this lack of control. Behavioral models. To understand the behavioral model of OCD, it is important to appreciate the Moira's two-stage model of fear and avoidance. This model is one of the most important in understanding the behavioral development and maintenance of OCD. Moira proposed that fear of stimuli, such as thoughts, images or even objects, can be acquired through the classical conditioning process. There are 2 stages to his model, where in the first stage, neutral stimuli can become conditioned stimuli through pairing with another unconditioned stimulus, one that naturally predicts the fear response. An example of this can be a person getting contamination obsessions after being seriously ill, or experiences of a family member being diagnosed and suffering from a serious illness. Another example can be a person having obsessions-related doubt after experiencing an accident at home due to fire/current, etc. The second stage of the model explains fear maintenance. He believed this happens through operant conditioning processes, i.e. behaviors related to escape and avoidance. Compulsions, according to this theory, thus can be seen as active avoidance behaviors that are negatively reinforced. They thus become habitual over time as they are successful in decreasing the fear and distress caused by the obsessions. The reinforced behaviors, in OCD compulsions, thus become difficult for extinction. Taking forward the example of a person with contamination obsessions, he or she may engage in excessive hand washing, taking long showers, or even avoiding public washrooms or not going near people who are sick so that the chance of contamination can be minimized as much as possible. The theory further proposes that other operant conditioning factors that maintain OCD are called as safety behaviors. For example, a person with contamination-related OCD using a cloth to open a restroom door. These are negatively reinforced as they help in avoiding and escaping from the anxiety momentarily, however, are seen as important factors that help maintain or even exacerbate the OCD-related symptoms. Cognitive models. Tsiolkovsky's cognitive behavioral theory. In 1985, Tsiolkovsky proposed the appraisals of intrusive thoughts, especially those linked to responsibility, and not just thoughts themselves, as an important cause of compulsions. The theory suggests that people with OCD view normal intrusive thoughts, urges or images signifying some harm to himself/herself or another, and thus impose a serious threat. People with OCD also tend to appraise themselves being responsible for the perceived harm, which possibly only they can prevent. This compels them to perform behaviors to reduce the harm whenever they experience intrusive thoughts/obsessions. Rachman's theory. Rachman took the previous theory forward and proposed the presence of two cognitive biases, which increase the likelihood catastrophic misinterpretations, some harm will happen to me or my family and I must prevent it, of obsessive beliefs. The first bias is a belief that thinking about an unpleasant situation will make it more likely for it to occur in reality. For example, if I get a thought about my mom being in an accident means she has gotten or will for sure get into an accident, whether or not that is true in reality. The second bias is more deeply rooted in morality. It says that having an immoral thought is equivalent to immoral actions. For example, if I get a bad thought, I am a bad person. Hence, with Rachman's theory, the phenomenon of thought-action fusion came to life. This will be discussed in detail later on in this unit. According to Rachman's theory, the compulsions are maintained because the person assumes a heightened sense of responsibility to prevent harm. The heightened sense of responsibility is influenced by the above-said biases in thinking. The individual is in constant doubt about whether the harm has been reduced or not. Thus, to remove this doubt, the individual constantly engages in the compulsive act to make sure the harm has been reduced. This phenomenon can especially be seen in people who have compulsions related to checking. Obsessive-compulsive cognition's working group model. A group of researchers, called the Obsessive-compulsive cognition's working group, OCG, first met each other at the World Congress of Behavioral and Cognitive Therapies, DMARC. They collaboratively came to understand OCD on the basis of three aspects: intrusions, thoughts, images, urges, appraisals, which are the interpretations one gives to the intrusions, and finally assumptions or beliefs about the appraisals. They identified 6 major belief domains implicated in OCD. These are: having an inflated sense of responsibility, I am responsible to prevent harm at any cost; belief that all thoughts are of importance, over-importance of thoughts, overestimation of threat, any situation can be or become dangerous; importance of controlling thoughts, it is important for me to control my thoughts, urges, impulses, intolerance of uncertainty, if I don't know what is happening some harm is likely to befall, and perfectionism, there is a perfect way to solve all problems and I must be perfect in doing that or else something bad will happen / I am not capable enough to shoulder my responsibility. Metacognitive model. The metacognitive model of OCD proposed that metacognitive beliefs about intrusive thoughts lead to maladaptive thinking, which they coined as the cognitive attentional syndrome, CAS. CAS consists of rumination, worry, monitoring of threat, as well as overt and covert compulsive rituals. All these are different ways of dealing with the distress associated with obsessions. Two domains of metacognitive beliefs proposed were of beliefs related to the importance of intrusive thoughts/feelings along with how dangerous these can be if not addressed, along with beliefs related to a need to perform compulsions. The first belief domain, also called as fusion beliefs, include three important beliefs. These are thought-event fusion. Presence of a thought can cause events to happen / belief that event has already happened. Thought-action fusion. Presence of thoughts can make a person engage in unwanted actions. And thought-object fusion. Presence of thoughts / feelings can be transferred into objects. The second belief domain consists of beliefs about rituals specifically. These are most often expressed in the form of declarative statements. For example, I should / must clean my hands till I stop thinking about germs / dirt, or can be seen as one preparing a plan to monitor their actions better. Family involvement in OCD. OCD can lead to many interruptions in daily functioning, causing distress to the entire family. Family accommodation in OCD refers to the changes that family members get in their own behaviors in order to help reduce the distress of the person suffering from OCD. These behaviors are also aimed at helping the person reduce the time taken in prolonged compulsive rituals. Family members have been seen doing the rituals as instructed by the patient. For example, patient may ask them to check the light switches, stove etc. These are also called as proxy compulsions. They may even sometimes get cleaning supplies such as soaps or detergents of particular brands to meet the demands of patients, choose timings of using washrooms according to the patient's needs, or even provide reassurance through verbal statements to make the patient feel at ease. While sometimes the family members themselves make these accommodations, at times patients demand such behaviors and can become aggressive or upset when these demands are not met. In the longer run, however, these are not helpful as patients continue to avoid confronting their obsessions and don't learn to tolerate the distress associated with them. This strengthens their obsessions and the OCD cycle is maintained. Higher levels of family involvement has been associated with increased OCD symptoms as well as poor functional and treatment outcomes. 9.3.2 Treatment of obsessive compulsive disorder. Cognitive behavioral therapy, CBT. Behavior therapy, BT, and CBT is often seen as the first line and important treatment in the management of OCD. The therapy focuses on exposure and response prevention, ERP, as well as challenging the idiosyncratic beliefs held by patients related to their obsessions and compulsions, some of which have been mentioned in the cognitive perspective above. In ERP sessions, the patients are encouraged to gradually face the anxiety-provoking situations while preventing them from doing any compulsions / rituals that can neutralize the anxiety. This is done by collaboratively making hierarchies of feared situations, rated on the basis of the distress it causes them, termed as subjective units of distress or SUDs. The therapy also makes use of behavioral experiments to help patients disconfirm their beliefs and expected consequences of harm. The sessions can range from 13 to 20 sessions held weekly / bi-weekly, with 3 to 6 booster sessions offered every month. Medication. Studies have shown that selective serotonin reuptake inhibitors, SSRIs, are effective in management of anxiety in the treatment of OCD. Other medications often considered in the treatment are serotoninergic tricyclic antidepressants such as clomipramine. 9.4 Body dysmorphic disorder. Ever looked in the mirror and thought, my forehead is so long, my nose is so crooked, my pimples are ugly, my eyes are terribly huge / small, my teeth are protruding out, what terrible hair, I wish I looked prettier. Well, we all have done this sometime or the other. Many of us do not feel good about how we look and hope to better change our appearance. However, how many times would you have engaged in such a behavior? Now imagine someone engaging in such behaviors and engulfed in such thoughts 24*7. Will that be distressing? Let us see what happened with Anisha, box 9.3, to understand better. Box 9.3, Anisha's story. 19-year-old Anisha, an undergraduate student, came to the hospital after a suicide attempt. Upon talking to her, it was found that she was obsessively preoccupied with how she looked. For years she referred herself as the ugliest duckling of the lot. When she was 15 years old, she had developed acne, which was highly distressing for her. From then onwards she experienced disturbed sleep, felt irritable and low whenever there was a breakout of pimples. She would keep thinking, if I touch my face and burst the pimples, they will grow back worse and leave scars on my face. I cannot deal with my acne. She said that her face was ugly and the pores on her skin are overly enlarged. She spends 5 to 7 hours per day checking her skin in front of the mirror or by opening her front camera on the phone. She further sometimes washes her face 6 to 7 times daily. She believes that, if I clean my face every hour and keep my skin clean, the pores will become smaller. I need to keep on checking my acne, otherwise I will not be able to manage the situation from getting worse. Several times she has scheduled dermatological consultations to ask the doctor for skin peels and medication. She further consulted the doctor for a cosmetic surgery, but was told that she did not need that. However, she continued to believe that her acne was terrible and the skin pores were enlarged. She feared others would make fun of her just like they did in school. She became socially withdrawn as she thought it's better to be by myself than go out with others making fun of me. If I go out I will anyway not have a good time, so what's the point? She would often feel restless in public places as she believed that others were making fun of her appearance. After overdosing on her acne medication in despair about her condition, her family members brought her to the hospital. She further reported that the doctors were not helping her with further medication and facial peels, which made her think that there is no solution left for her acne. She felt hopeless and worthless, which led to the suicidal attempt. An Italian psychiatrist by name of Enrico Morselli was the first to talk about dysmorphophobia in 1891. He believed that this condition is a subjective feeling of ugliness or physical defect which the patient feels is noticeable to others, although the appearance is within normal limits. The dysmorphophobic patient is really miserable. In the middle of his daily routines, everywhere and at any time, he is caught by the doubt of deformity. The current conceptualization of body dysmorphic disorder, BDD, is in line with what he mentioned and includes a preoccupation with appearance, being excessively self-conscious, including disproportionate concerns about minor flaws, as well as excessive and repetitive anxiety-provoking thoughts about their imagined defects. Patients with BDD often find themselves engaging in repeated mirror checking, comparing their appearance with others, overly engaging in grooming themselves, and can also resort to skin picking when feeling distressed. They may seek reassurance from their family or close friends, which can maintain this cycle of preoccupation with their looks. You may often find patients dealing with these difficulties first seeking help from dermatologists and plastic surgeons rather than mental health professionals. DSM-5 also mentions that this preoccupation with appearance must not be better explained by them having concerns about body fat/weight and should not amount to an eating disorder. It also requires investigations to be made for muscle dysmorphia, as well as establishing the insight levels as being good, fair, poor, as well as absent insight with or without delusional beliefs. To understand the phenomenology of BDD, let us look at some important key elements of the disorder. Body image. An individual's subjective sense of body image majorly influences their overall quality of life as compared to the objective reality of their appearance. Patients with BDD feel extremely handicapped even though objectively they appear to have a normal appearance for others. This discrepancy between their perceived body image and the true reality leads to stigma experienced by them. Body image valence. This refers to how satisfied or dissatisfied one is with their body image. While some people may not like certain attributes in their body, they may not value their overall appearance as much as other aspects such as family, relationships, career, etc. For people with BDD, a high level of valence is placed on body image, whether they not only have former but also negatively evaluate their body image. Overvalued ideas and delusions. People with BDD have extreme values related to importance of appearance which significantly impacts their self-concept. However, they are ignorant to the consequences that come along with it. Other than appearance, some people also tend to place symmetry or perfectionism as highly important, whereas others value being socially accepted, which they think will happen only if they have a normal appearance. These overvalued ideas and beliefs can sometimes take the form of rigid, unshakable beliefs and turn to delusions. Metacognitions and ruminations. Rumination for people with BDD can take the form of mental imagery and thoughts about being defective, ugly, thinking about the whys. Why am I so ugly? Why did my nose have to be so imperfect? The whats and what ifs. What will I do if my acne doesn't get better? What if I never look better? Self-punishing thoughts. You deserve to be laughed upon as you are so ugly. Reviewing past experiences as well as worrying about the past and future, which further leads to anxiety. Shame, social anxiety and perfectionism. Body shaming, an integral phenomenon in BDD, can take on a social /external evaluative form, someone thinking they are inferior, bad or ugly. Internal form, being critical and nagging /punishing oneself. Emotional form, evoking feelings of self-disgust, hate, anger and humiliation. And a behavioral form, avoidance of people and places, trying to meet others' standards. The fear of being negatively evaluated is often present in people with BDD, thus it is not uncommon for them to report symptoms of social anxiety disorder. People with BDD have further been found to have perfectionistic standards of appearance and behavior and are highly critical and harsh in evaluating themselves. Safety-seeking behaviors and compulsions. Safety-seeking behaviors are any attempts at reducing harm or a perceived catastrophic event. People with BDD often find themselves engaging in safety behaviors such as camouflaging, mirror checking, avoidance or distracting the attention from specific disliked features of the body, verifying features directly, using one's phone or the mirror, comparisons with others as well as reassurance seeking. Prevalence, age of onset, and gender differences. The prevalence in USA has been estimated to be around 1 to 2% in the general population. BDD seems to be more frequent among patients seeking cosmetic treatments, with 6 to 15% of the patients being diagnosed with dermatologic conditions. Prevalence of BDD in dermatological and plastic surgery patients have been reported to be 8%, 15% and 3%, 53% respectively. BDD is a chronic disorder, with an average duration of 15.7 years. Milder symptoms, however, may be episodic and aggravate during stressful periods. Furthermore, family history data suggest that 6–10% of first-degree family members have BDD. The mean age of onset for BDD is in adolescence, as in the case of OCD, with community studies indicating a higher prevalence of females with BDD. Family and twin study data provide preliminary evidence for genetic susceptibility. Studies also reveal that males are more likely to be preoccupied with small body build, small penis size, thinning hair etc., while females could be preoccupied with their weight, breasts, hips and excessive body hair. Women have also been found to perform more repetitive and safety behaviors, are more likely to camouflage their appearance using techniques like mirror checking, changing their clothes, picking their skin, as well as having an eating disorder. Studies with BDD patients show an equal sex incidence in people whether they are single or separated. Commonly seen in adolescents and young adults, this disorder is rarely seen among the elderly. Comorbidity. BDD is often underreported or underdiagnosed due to shame associated with the disorder. When patients with BDD do seek help, they often presented with comorbid conditions such as major depressive disorder, social phobia, obsessive compulsive disorder, and substance abuse disorders. 9.4.1 Etiology and treatment of body dysmorphic disorder. Etiology, neurobiological model. Neuroanatomical structures of the limbic system including amygdala and insula are implicated in BDD. It has been found that lesions in somatosensory cortex led to loss of perception, while those of the right temporal lobe are responsible for one experiencing deficits in their visual field, experiencing mood alterations, and can lead to disorders related to body image. Lesions in the parietal lobe have further been found to have links for development of BDD. Abnormalities in serotonergic responses lead to exaggerated inhibitory response in the frontostriatal circuits. This is a neurotransmitter circuit which is involved in reducing anxiety. The changes seen in the serotonergic system thus may not be involved in someone developing BDD directly, but can result as the system becomes overloaded as one's anxiety increases. Hence SRIs may be involved in the management of this condition. Behavioral model. Positive reinforcement of experiences with situations involving one's appearance has been found to play an important role in the development of BDD. Especially when these are encountered early in life, a child may start believing that appearance is of ultimate importance. Negative experiences further have shown to have an impact on BDD. Instances of trauma linked to sexual and emotional abuse, skin conditions like acne/psoriasis, teasing, neglect, bullying, etc. can result in the person giving over importance to appearance, to the point of creating distress. Vicarious learning happens when people see others being reinforced on the basis of their appearance. This can especially be seen by the influence of television advertisements of beauty products, beauty pageants, or movie actors advocating specific looks via their body type, clothes, etc. Cognitive model. The cognitive model of BDD places importance on a phenomenon where people start seeing the self as an aesthetic object. Seeing oneself in a mirror can often act as a trigger, which is then described as a self-perceived representation of a person's appearance than their true self. Internal triggers include somatic sensations, feeling puffy under the eyes, tingling sensation in acne-prone areas, as well as intrusive thought, "Why is my nose so crooked?" This makes an individual engage in self-focused attention where he/she becomes excessively aware of one's body image, but from an observer's perspective. The main components of the self as an aesthetic object are mental imagery. This is an impression or representation of how they think they appear to others. It can be negative, recurrent, and vivid, where the perceived distorted and the defective features are severely highlighted. Self-focused attention / cognitive fusion. An individual with BDD may compare his / her appearance with others. When someone close is perceived to be more attractive, the person may switch into a defensive mode. This will lead to activation of safety-seeking behavior, which protects the individual. He/she may also attempt to escape from the situation or camouflage themselves/or their defects and avoid any perceived threat, for example, keeping the head down, covering face with some hair or scarf, avoiding eye contact, wearing excessive makeup, etc. Lack of a self-serving bias. People with BDD may choose to attend to only those features that they consider to be defective, which leads to an experience of self-depreciation of their appearance. Each of these components lead to one believing that they are nothing more than an aesthetic object, eventually raising questions about their body image and self-concept. Treatment: Cognitive behavior therapy, CBT, for BDD. CBT for BDD and has been shown to be effective for adults. The treatment is focused on trying to understand the patient's assigned valence to his/her body image, their self-appraisals of situations, cognitive biases, safety behavior and avoidance, which may be maintaining the condition. CBT for BDD uses techniques such as imagery rescripting, modifying beliefs and appraisals, working through attention biases, graded exposure tasks as well behavioral activation, in cases of depression comorbid with BDD, in the treatment of BDD. Medication for BDD: in milder cases of BDD, medication may not be the first line of treatment. However, if the BDD symptoms worsen or have been maintained for long enough, then pharmacotherapy may be recommended. Antidepressant medication, serotonergic reuptake inhibitor, is often used in treating moderate to severe BDD. 9.5 Let us sum up. ORCDs include OCD, BDD, trichotillomania, hoarding disorder and excoriation. Obsessions are repetitive, persistent, intrusive thoughts, images, or impulses that are distressing, inappropriate, and ego-dystonic. Compulsions are overt and covert repetitive behaviors that are performed as lengthy rituals that help neutralize anxiety. OCD is the fourth commonest mental disorder with disability in severe cases, with age of onset in adolescence and a worldwide lifetime prevalence rate of 1.5% for women and 1% for men. The orbitofrontal thalamic loop along with neurotransmitters serotonin, dopamine and GABA are primarily implicated in development of OCD. Psychoanalytic view sees development of OCD as a result of fixation at and regression to the anal sadistic stage of development. It proposes two personality types, namely anal retentive and anal expulsive personality. It also views OCD developing from a conflict between the ego, superego, as well as aggressive and sexual impulses emerging from the id. The behavioral perspective on OCD has focused on the MOA's two-stage model of fear and avoidance behavior. In the cognitive perspective, Salkowski's proposed phenomenon of appraisals of intrusive thoughts, responsibility-related appraisals, Rachman proposed cognitive biases lead to catastrophic misinterpretations of intrusive experiences. The OC proposed 6 major belief domains in OCD, and the metacognitive view proposed importance of metacognitive beliefs. BDD involves a preoccupation of a person with appearance, being excessively self-conscious, including disproportionate concerns about minor flaws as well as excessive and recurrent, anxiety-provoking thoughts about an entirely imagined defect. Key elements identified in the phenomenology of BDD are body image valence, overvalued ideas and delusions, ruminations and metacognitions, shame, social anxiety and perfectionism, safety-seeking behaviors and compulsions. The mean age of onset for BDD is in adolescence. It seems to be more frequent among patients seeking cosmetic treatments and in patients diagnosed with dermatologic conditions. The serotonergic system is not implicated in the development of BDD but could be the result of overloaded systems associated with BDD. Behavioral models view positive reinforcement of experiences with physical appearance to play an important role in the development of BDD. Instances of trauma linked to sexual and emotional abuse, skin conditions like acne/psoriasis, teasing, neglect, bullying etc., as well as vicarious learning can have a significant impact on development of BDD. The cognitive model of BDD emphasizes on the experience of the self as an aesthetic object, with its main components being mental imagery, self-focused attention / cognitive fusion, self-focused attention and lack of a self-serving bias. While therapy, especially CBT, appears to be the first-line treatment in both disorders, SSRIs are also usually considered in treatment of moderate to severe conditions.